Welcome, everyone. Thank you so much for joining us for the inaugural session of the Jane Family Institute's Social Wealth Seminar. I thought at the beginning I could just say a couple of words briefly to introduce JFI and the seminar before introducing our presenter, and then moving right into the presentation and to questions. Here at the start, I just wanted to say a quick couple of words about JFI. But I guess first I should introduce myself. My name is Paul Katz, and I am Vice President for Special Projects at JFI. The Jane Family Institute is an applied research organization in the social sciences based in New York City. And we work on three major focus areas. We've got alternatives to student debt and access to higher education is one. Digital ethics is another. And finally, guaranteed income is our third area. And it was actually our work in guaranteed income that was kind of the source of the germ of the idea that has emerged into, bloomed into the Social Wealth Seminar. In fact, we've been collaborating, among other partners, with a really fascinating city in Brazil, the city of Maricá, about an hour outside of Rio, which has been the recipient of a really large windfall from oil royalties. They're located adjacent to the most productive drilling site off the entire Brazilian coast. And they have really used this, unlike the beneficiaries of so many commodity booms in the past, to invest in an entire suite of policies that they characterize as an attempt to build a solidarity economy. And that includes a basic income, which currently covers about a quarter of the neediest people, or a quarter of the population, the neediest quarter in the city. And other programs, such as a baby bond-like program of savings accounts for high school students. They built a new hospital and other initiatives in public health, a farm school that they've constructed together with the landless workers movement, just really an entire free public transportation, an entire set of policies that really had us thinking, at this particular moment, like we should be thinking big. And not only in the city of Maricá, not only in the United States, but across the world. So we kind of conceived of the seminar as a place to bring together scholars, activists, academics, thinkers around questions of public resources, municipal finance, social wealth funds, basically how to manage public resources and assets in service of social justice. And that's kind of the broad theme, and we're excited to take it in many directions over the course of the coming months. We see the seminar as an open-ended forum. It will meet every 2 weeks on Tuesday at 6 p.m. Eastern Time, with some flexibility if we need to move. But the idea is to have this kind of be an ongoing forum for this conversation, which hopefully can take place over a very long span of time. So we have a couple of upcoming sessions already scheduled that I just want to very quickly flag. First, on Tuesday, July 21st, so 2 weeks from now, we'll hear from Jaco Fagan, who is the Associate Director of the Future of Capitalism Project at the Berggruen Institute. And he'll be talking about sovereign wealth funds and public wealth building institutions in the context of the global dollar system. Then 2 weeks after that, on Tuesday, August 4th, we'll be hearing from Amanda Cass, who's the Associate Director of the Government Finance Research Center at the University of Illinois at Chicago. We'll speak about public pensions in the wake of COVID-19. And then finally, the last session that we have already scheduled is Tuesday, August 18th, when Carla Santos Scandier will be speaking. Oh, she's the co-manager of the Climate and Energy Program at the Next System Project. And she'll be speaking about non-extractive finance mechanisms for a just recovery and transition. So we've got a really, I think, interesting and diverse slate of presentations scheduled for the next 2 months. And I just want to underscore that because this will be an ongoing forum, we are interested in receiving proposals from anyone who is interested in presenting, or who can think of someone else who they might want to see present and who might want to moderate that presentation. So if you're here in the session, I think you have my email address. So please do shoot me an email. We would love to hear proposals. And just a last thing to mention in this quick little introduction to JFI is that we have a weekly newsletter and a very exciting blog called The Phenomenal World, both of which are there for your reading pleasure. So please do check them out, subscribe to the newsletter if you haven't subscribed yet, and be in touch if you have any questions. All right, so this, of course, is the first meeting of our Social Wealth Seminar, and we are absolutely thrilled to welcome Naomi Zewde, who will be speaking about inequalities in health and wealth, things to consider when building a generation. In just a second, I'll be introducing Naomi in more detail, but I just want to speak briefly about the format of our meeting today. We'll ask that you please hold questions or points of discussion for the end of the presentation, but if you'd like to raise points of clarification throughout, please add them in the chat, and then we can address them directly. I just also want to note that we're going to be recording this session, and we'll be posting a lightly edited version to our YouTube channel for those who can't make it. So do be advised if you want to, not kind of appear, then make sure you have your video off and don't speak out loud. But of course, you can share anything you'd like in the chat. So a last little thing here at the beginning, a little bit of housekeeping, is just to share a word of gratitude to those who have helped make this seminar a reality. So the first set of people I'd like to thank are JFI's really amazing editorial department, Molly Dekchar, our editorial director, Jack Gross, who's the editor of our Phenomenal World publication, Maya Adarith, who's our editorial lead, and most especially Hala Ahmad, who is our PR lead. This set of people has been absolutely critical, both to thinking through the seminar and to making it a reality. So thank you so much for all of your help. I also want to give a shout out very quickly to Daniel Hertz, who's policy director for the City of Chicago's Department of Housing, who is also really critical in kind of helping me, as those who were here a couple of minutes ago as I was awkwardly chattering may have heard. Really helped me to kind of think through the seminar and to plan it out. So thank you so much to Daniel. And finally, thank you so much to our presenters and to all of you who are present for joining us today. So, all right, that is definitely enough of a preamble, and I think we are finally ready to get started. So before I pass the word to Naomi, I would like to introduce her for all of you who may not yet have had the pleasure of meeting or virtually meeting her. So Naomi Zewde is an assistant professor in the Graduate School of Public Health and Policy at the City University of New York and a research fellow at the Roosevelt Institute. She is formerly a postdoctoral research scientist in social work at Columbia University, a member of the research staff at the Penn Wharton Budget Model, and a research fellow at the U.S. Department of Health and Human Services. Her research centers on economic inequality in wealth and in health insurance and examines the ability of public policies to reduce these inequalities. She has a series of studies on the economic impacts of the Affordable Care Act for the previously uninsured and the effects of Medicaid expansion on poverty and rates of home eviction. Her work has been published in Health Affairs, the American Journal of Public Health, the International Journal of Health Economics, and the International Journal of Health Economics and Management, and has been covered widely in popular press outlets, including the Washington Post and NBC News. Zewde holds a PhD in health policy from Penn State and an MPH and BA from Emory. So without further ado, I'd like to pass the baton to Naomi. Thank you so much for joining us today.
Thank you for that introduction, Paul, and to everyone who made this happen and to everyone who is here. I'm excited to do this. So I am going to share my screen, and I think it's going to work. Sorry. I hate when people have technical difficulties, but we'll keep them to a minimum. Okay. So, wealth, health, and power. All right, so let's get into it. Basically, what we have are two inequality problems, and one of them is happening over here in the middle of your screen, and that's this median problem. And that's the fact that at the median, the white household at the median has 10 times the wealth of the median Black household, $160,000 versus $16,000. So that is like a really meaningful difference in terms of what you have access to throughout your life and just like the experience of living. Then there's this other problem that's happening at the right-hand side of our screen, and that's at the 99th percentile. And that's the fact that there is most of the wealth in general in the United States is concentrated in the hands of a few, like a billionaire class, which is also a white billionaire class. But not, not all of the wealth that happens to escape the hands of that white billionaire class also doesn't equitably distribute itself between races in the rest of the economy. So we have both of these problems at our hands, the everyday family and their racial inequality, and then the wealth that's concentrated in the hands of the few. And we kind of have to confront both of these issues, in order to design a just economy that is able to deliver high quality goods and services to everyone. We have to be able to have power over institutions and shared power over institutions and resources. All of the power can't be concentrated in the hands of the few. And the whole point is to be able to equitably distribute access to resources and power. So, in order to have racial justice, we need economic justice. Just to kind of lay out what that means real quick, how unequal is the wealth distribution exactly? Let's say that we were to take 100 people to represent the United States and $100 to represent all of its wealth. One thing that we could do is just to give each person $1, right? That would just be like 100% equal. So that's not what we do. The first thing that we do actually is we give $40 to the first guy. And I'm saying guy because actually 90% of the world's billionaires are men. Now we give the next $40 to the next 9 people. And then that leaves us with $20 to sprinkle across the other 90 of us. And in reality, the last few owe the first few. So it's a little bit worse than what I'm showing you. Not only is it just super unequal, it is getting worse over time. That even after the Great Recession, like the value of wealth drops a little bit at that 99th, 100th percentile, but then it just takes back off. So what's happening is like, as computers are entering into our economy and making everyone's labor like far more productive, that's not exactly being realized. Like the increase in productivity and wealth that's created is not really being realized by everybody. It's really only being realized by people who own capital or who own businesses. So it's not just concentrated, it's getting worse. And actually the racial wealth disparities too, the median problem, it's also getting worse. In 1983, the median white family had 10 times the wealth of the median Black family. In 2016, it's 7 times as much. This is from the Urban Institute. So anyway, it's getting worse on both counts. And so this is wealth specifically that we're talking about here and not income. Both are important, but wealth itself plays a role that is independent from income. Income comes in every month and you use it to buy whatever it is that you needed. Wealth, on the other hand, is a stock. It's not a flow. And so it's something that you draw upon in times of need. It acts as insurance. We know that consumers, value having insurance, even if you didn't necessarily really utilize the benefits of that insurance necessarily, you get something from knowing it's there. And also independently of income, wealth predicts, 2 or 4 year, like attendance at a 2 or 4 year institution of higher education and also graduation. And it also just confers a kind of social standing or community influence. Like you're able to, let's say, open a business, hire other people, sponsor the Little League team, whatever it is, like it gives you a standing that's something independently from having the income and the ability to meet your basic needs through income. So the problem, there has been policies that were attempting to address this issue or trying to like subsidize the creation of wealth and among populations that lack access, but they've had some flaws in their design. So for example, 529 is like a college savings program that parents can participate in. But the way that it like encourages investment is by giving you tax breaks, which means, first of all, you have to earn enough to pay taxes in order for that federal tax break to mean anything. And also the more you earn, the more that tax break means because you have a higher marginal tax rate. What ends up happening is among those households that are eligible to participate, like with a child eligible to participate, the median wealth of the ones who participate is 25 times the median wealth of those who do not. And then another issue with, they have like individual development accounts. It's something where, you know, some households who are in poverty can put some money away from their income. And then if they are able to save it over some number of years, then this program will match it, let's say even up to 4 times as much, so that you can use it if you withdraw that money after waiting in order to like use it for a home down payment, or there's like a couple of approved options. But what ends up happening is that like people end up having to dip into that money before they've waited like the requisite number of years. It's just like hard to save when you're poor. I mean, poverty almost by definition means that you are not able to purchase your basic needs with your income. So it's highly likely that people are going to have to dip into that. And what they found with a randomized control trial is that, you know, 10 years after program completion, they couldn't really detect any differences between those who were randomly assigned and those who were not. So the idea of baby bonds, which is something that like my colleague Derek Hamilton had the idea of, and then I did an empirical evaluation of more recently. But basically the way it would work is that it's like a universal trust fund account for every newborn baby in the United States. And the money is seeded by the federal government. So, you know, we're not relying on parents to have like ties to financial systems or to have initial seed capital either. So it's universal, everyone gets something, but those parents who are the least wealthy would get the most, up to $50,000. The parent can't touch it, neither can the child, but they also didn't put the money in, but no one can touch it basically until they become a young adult. At which point the kid gets control over that money and also whatever interest has grown, you know, since they were born. If we were to implement something like this, it would cost about $80 billion per year. SNAP is like 73 billion, so it's definitely feasible. But then the question down here is, could we really make headway on those two big wealth issues that I pointed out at the beginning? So I wanted to know, and I used data from the panel study of income dynamics, which is a longitudinal study since 1968. They've been following a representative sample of American households, just like for generations ever since. And then they do like immigrant refresher samples every once in a while. So I got, you know, a representative sample of young adult households in 2015. And I was like, okay, if we had this program in the late 80s, early 90s when they were born, based on the wealth of their parents when they were born, which you have in that data, what would wealth inequality look like today? So without any baby bonds today, among young adult households, white households have like 16 times the wealth of the young Black adult household. This is like earlier on, before they've had, you know, their whole careers to build up all of their wealth and everything. But still, even at this age, around 20, like between 20 and 25, you've still accumulated sometimes like, you know, money from your parents to put down a down payment, whereas other people might have taken out loans and have a net negative. So we do end up finding racial inequality differences. Also, incidentally, a lot of the intergenerational transmission of wealth happens not necessarily at inheritance, but throughout the life course. The intergenerational correlation in wealth is really strong, you know, throughout the life course. So anyway, so we find without baby bonds, we have this, this racial inequality in wealth at the median among young adult households, but with baby bonds, we still find a racial inequality at the median, but it is reduced from a factor of 15.9 to a factor of 1.4. A part of what was important about the design of baby bonds being based on household wealth, in terms of like the progressivity of the bond, like giving more money to households where the parent is less wealthy as opposed to has a lower income, is just because like wealth relative to income is far more racially inequitably distributed, because wealth is that generational thing that happens from parents and grandparents to kids. It's, you know, African Americans have only really had access to occupational options and educational options in like the 60s till now. So it hasn't been very many generations to acquire, accumulate, and transmit wealth across generations. So that's why this program is designed in that way. And so what happens is, you know, you can substantially reduce this racial wealth gap by intentionally designing it to address that. So, and the reason that happens is because you're lifting wealth a lot more at the bottom end of the distribution than you are in the middle and then at the top. So a program like baby bonds could meaningfully improve people's well-being. The Federal Reserve measures these indicators of economic well-being, like can you borrow $3,000 or do you expect to inherit money? And we find a lot of racial inequality in responses to those things. I think 26% of white people say that they expect to inherit money, but only 5% of Black people do. So something like this, do you expect to come into a sum of money in your young adulthood, would be meaningfully changed by something like baby bonds. And it does that by raising wealth for all groups in a way that moves towards egalitarianism, and it can prevent future poverty and prevent future need. But it does not address the plutocracy problem. That doesn't mean we shouldn't do it. It just means that, a few tens of thousands of dollars does not necessarily reorganize society. We also have to improve the way that our institutions are constructed. And when I say the plutocracy problem, it's not that there are any particular individuals whose personalities are a problem. That's not individual personal shade at anybody. The fact is that the sun, is 400 times the size of the moon, but it's so much further away that it can be completely eclipsed by the moon. So it's just whatever problems are within your sphere are going to look bigger. And if you sit atop a bunch of resources, you're going to allocate resources to solve those problems. But without sharing, power over resource allocation, then our institutions aren't necessarily going to address the most dire problems, only the problems that come into the purview of whoever it is that has power over those resources, right? So on the left, COVID cases by zip code within New York City, that's where I live, and maternal mortality cases by zip code, which, by the way, maternal mortality, totally solvable problem. Not something that we need to have our top scientists figuring out. It's really just about relationships and resources and access and consistency. But what happens is these inequalities end up perpetuating themselves because institutions don't necessarily represent the people that they serve. In the US in general, healthcare is just highly inequitable. So 39% and this is just above and below median income households in the United States within the past year. This was in 2015 that this came out, but 39% of them needed to see a doctor, decided not to within the past year because of the cost, and 17% of high income households. But the thing is, even high income households in the United States are worse off than the low income households across the OECD average. So the US healthcare institutions, they aren't really designed to serve the population's needs. On the left, healthcare spending as a percentage of GDP, you might have seen this if you've ever been around a health economist, but the US is that black line with those squares, and it's far and away, we're spending a lot more than anybody else is spending. And then on the right, life expectancy at birth, we're not getting anything in return for all that money that we're spending. We are, again, far and away the outlier, but in the wrong direction. We're not consuming any more healthcare than people in other countries. The US has fewer than average physician visits per capita, fewer than average physicians per capita, and we have more than average adults who have, for example, multiple chronic conditions. So we're not any healthier, we're not getting any more healthcare for all of the money that we're spending compared to other countries. So what ends up happening is that we're paying more and more every year for coverage where the quality of that coverage is falling. Deductibles continue to grow faster than wages. And so employees have to make concessions, whether it's explicitly in union negotiations or implicitly when an employer is considering, the marginal employee, the cost of that marginal employee is a total compensation package, right? And this is across every US industry. They're all being taxed by our outstandingly inefficient healthcare system. Labor would cost less if healthcare costs less. And this also advantages large businesses relative to smaller ones. They can self-insure, that can reduce their administrative risks. And if you're a small business and you're trying to buy coverage, you can't offer your employees anywhere near as good of coverage as a larger business can at the same price or even at a comparable price. So it's harder to attract top talent when you're a small business. And the thing is that there are so many different little pieces to this administrative healthcare puzzle. There's so many different insurance companies. They all have their own prices. And then every doctor's office has to hire a couple of people to figure out which forms to fill out for each of them. So and then all of those people have also health insurance that we have to pay for. So it's just a really inefficient picture because there are so many different little pieces to it. So, what we have every year, the top line is deductibles growing faster than anything else, premiums next, and then wages last. over the past more than a decade. So people are getting squeezed. This is just, I don't know, funny, but if you're a Redditor, somebody did an AMA where they asked me anything. So I was mauled by a bear and I fought it off, drove 4 miles down a mountain with my face hanging off. Ask me anything. Someone says, what was the hardest thing to overcome in your recovery? She says, Blue Cross, hands down. It's kind of a nightmare. It's kind of an administratively complex nightmare that a lot of people have to deal with. So this was, pre-COVID, this was kind of the landscape that we were dealing with. And the most recent major reform that we, trying to improve our healthcare and insurance institutions was through the Affordable Care Act. So with the ACA, we had 2 pieces of the ACA. One was the expansion of the public coverage and one was the private. This happens to be from the CBO's numbers, Congressional Budget Office, but similarly with RAND, Lewin, CMS, everybody pretty much, they way overestimated the number of people who would enroll in these private insurance exchanges. On the left, you can see like the actual number is well below their initial projections. And then on the right, the exact opposite thing happened with participation in Medicaid expansion. So the lighter number, the lighter line, March 2010 projections, that was before the Supreme Court decision came out saying that only some state, whoever wants to expand at the state level can. So they had to revise it downward in May 2013 prior to the actual implementation of the program. So comparing actual enrollment to their May 2013 projection, you can see this huge difference. So like they were off by like 10 million people total between the two, and only 20 million people got coverage through the Affordable Care Act. So they thought a lot more people were going to want this private insurance than did, but it turns out a lot more people wanted the public than they had figured. And we find, and these are 2 of my papers, but this is drawn from a voluminous literature on the household economic benefits of the expansion of Medicaid. So we have a reduction in the rate of poverty among households in the United States. And we have a reduction in the rate of home eviction in the United States after the expansion of Medicaid. At the same time, when you look at the private insurance arm of the ACA, this is like a paper I have that's under R&R right now. But so if you look at the population of people who were uninsured prior to the ACA and who were not eligible for Medicaid, basically just like the target audience for these exchanges, for 1 in 4 of them, it's cheaper to file for bankruptcy than to reach the deductible of the subsidized benchmark tier of private insurance coverage under the Affordable Care Act. So it cannot offer financial protection to this population of any kind. And for some of them, it happens to be maybe a little bit cheaper to reach the deductible than to file for bankruptcy. But still, for a lot of people, it's just like the deductibles are too damn high, So that's where we were prior to COVID. And we were also debating, so now what are we going to do next? Do we do a public option? Do we do single payer? This was, this is where we were, just as a reminder, because I feel like the last, few weeks have really like eclipsed everything else. But interestingly, so I've been kind of thinking about what is a public option and what would that mean. So just looking at the documents from when they were trying to figure this out, when they initially made Medicare for seniors, they were trying to decide if they should do a public option. And they decided not to do a public option in particular. Number one, because they're like commercial insurers because insurance is something that, where it's beneficial to have a large group. So commercial insurers that are obviously going to be smaller than the federal government simply cannot offer equivalent benefits at a lower cost, even if we're not going to consider the fact that they probably want to maximize their revenues and they want some kind of profits, perhaps. Even, outside of that, assuming that they, actually don't care about those things, which they do, it will be difficult for them to really be able to offer something on par. And they also point out that like free choice when it comes to picking your doctor, your hospital, your clinic, your facility, when, how you're going to get care, that is like very meaningful. But free choice when it comes to the option of paying more for less protection isn't necessarily a policy priority that we need to go out of our way to protect. So anyway, in my own analysis, what I find is that probably what we see with the public option is that best case scenario, we totally destabilized the private market and it was kind of a waste of time. So we know from the literature that consumers when they're choosing insurance, they are highly price sensitive. Something like 75% of people in the non-group markets under the age of 35 would go from a broad network plan to a narrow network plan to save $30 a month. So, and for the population overall, it's something like half of them would be willing to do that. So if we're going to introduce a public option that meaningfully improves affordability while still offering high quality access to high quality healthcare services, we can expect substantial consumer migration. And because of the nature of insurance markets where you need to pool a lot of people together, that could be highly destabilizing to the private markets. States who are actually in the process of trying to figure out how they can design their own state public option plans are designing plans intentionally to minimize disruption, which basically means like it can't be too attractive. But in the best case scenario, the public option is so attractive, it is just attractive, period, and thus destabilizes the private market. Even in that instance, though, we're still kind of faced with this problem, with the inefficiency problem that's setting the United States so far away from all of these other countries. It doesn't actually address that complex puzzle, it adds another piece. And also, it might still be inequitable. How are people going to pay for this coverage? Are they still going to have, the median deductible in the ACA marketplaces at the benchmark tier is $4,000, meaning you pay your premium every month, you pay for all of your healthcare services out of pocket, because most people are not going to exceed $1,000 or $2,000 in a year. So, basically this is a paper, this is like a work in progress, but using data from the MEPS and some other different sources. If you look at like the total out-of-pocket expenditure, premiums, and direct spending on care, what happens is that as household income increases, the percentage of income allocated towards healthcare is declining. And if we gave everyone a public option, and this is designed to be really the most affordable possible public option, getting people the option to buy into Medicaid networks, which are just like a lot cheaper than private insurance networks, but still having the ACA subsidies. So it's going to reduce the amount of money that people have to spend on healthcare for sure. It is an improvement on the status quo. It still retains, though, that unfair shape where, anyway, not even to put any qualifiers on it, it does retain the same shape in which at lower levels of household income, higher percentages of income are being allocated towards care. With something like a tax-financed healthcare system, you get to decide what percentage of household income is being allocated towards healthcare. So that is as long as it's being financed through taxes, you get to choose. You can choose if you want to make it progressive or if you want to keep the shape the way it is. So in the state of New York, where I live, we have something called the New York Health Act. That is, it's basically like a Medicare for all, no deductibles, no copays, no networks. It would just be 100% tax-financed healthcare for all the state residents. It passes the lower house and the assembly every year. We are one senator away from a majority co-sponsoring the legislation. Cuomo says he won't veto it, but it's been sitting at that political stalemate for a while. But Rand did this simulation last year, and anyway, what they find is that even though healthcare consumption will increase because there's no deductibles and there's no uninsured people and everything, still we are allocating fewer total resources, macroeconomically speaking, to the production and consumption of medical care just by having like that unified system. So the unified system makes it more efficient, and the tax finance aspect makes it as equitable as we choose to make it. And I think that that's something that health economists in general tend to agree on, but there is this big political barrier in our way of just kind of thinking that, well, it's just impossible because that's not how it happens now. It can never happen that way. So, just to leave you with the slide that I started on, 1 in every 1,500 African Americans so far has died of COVID. And we have a healthcare system that is like super extractive. If you think about electronic health record, physicians hate electronic health records, and they were really designed for the purpose of billing and encoding, and not necessarily for the purpose of just like assisting in the provision of care. So for example, we weren't able to use those to track COVID, because they're not designed for that. Our institutions, and specifically our healthcare institution, is really designed for the purpose of extracting and not necessarily serving. And so that does not serve those who don't have excess capital to throw into that market. And so what we end up with is those two problems. The fact that our institutions are not, shared widely, power over those institutions aren't necessarily shared widely, and also the experience of that is so disparate by race. And so it's like two problems, but they're also the same, and there are also a million others, because it shapes so much about the way that we live our lives. So, but, you know, we've had these kinds of programs in the 20th century to build the middle class, like the New Deal and the GI Bill, and they were really successful. And we can do that again, and this time not make it racially exclusionary. And I think it will be successful whenever we decide to do that. That's it. Thank you.
Well, thank you so much, Naomi. I really can't imagine a kind of better start to the seminar than such a compelling, well-evidenced, and extraordinarily broad presentation. So thank you so much for getting the juices flowing with that.